Okay, fantastic. So let me thanks everybody for joining in on time, and we'll for the benefit of all those people who are here already, let's get on with it. It's 9 p.m. Today, and we are actually now on our 34th Zoom session of UMANG. And this time the topic is on navigating the path ahead, the small hospitals in India's evolving healthcare landscape. I'm one of your hosts for the day today. My name is Gautam Goyal. I'm a general and laparoscopic surgeon practicing in Shivaji Park, Dadar, with a special interest in diabetic feet, varicose veins, and laparoscopy. And co-hosting with me is Dr. Vidya Kadam. Vidya, can you take it on and introduce UMANG to everybody as well?
Yeah, thank you, Gautam. Good evening, everyone. So already, as Gautam has said, it is 34th session today, and UMANG was about UMANG. Two words I'd like to say is that it was created by like-minded medicos coming together for expanding the horizons beyond the limitations of professional learnings. So it's a different kind of CME basically. It's not academic, not medical CME. It's like a creative medical evolution through various insightful, inspiring and interactive online sessions. And here you have, it's across the medical community, even start from the junior doctors to the very senior doctors and across all specialties, and the people who are practicing in as the ones who are purely academicians. So I welcome you all. I am Dr. Vidya. I am a co-host with Dr. Gautam, and I'm a nephrologist practicing in Thane almost last 20 years. And I run my own nursing home, which is like 40 bedded, which is a multi-speciality, and I am attached to Jupiter and Hiranandani Powai as well. So here, let's start our topic today. Gautam, would you like to introduce the panelists?
Yeah, please introduce. Yeah, please start to that. So actually it gives me great pleasure to introduce two of my very close friends. Manoj is a co-surgeon practicing in the same area. He's a year my senior, but an absolute contemporary, wonderful friend and a great backup to know that you have around the area you're practicing in. He himself is basically a very accomplished laparoscopic and bariatric surgeon who's done his training in Beyond Bombay in UK. He's done robotics from Italy. He's got his diploma in advanced lab from France. And he's more importantly, he is a person who owns a successfully running hospital or a small hospital or a nursing home. And besides this, he's also attached to various corporate hospitals. So he's got his fingers in all various pies, and he understands the difficulties and fruits of them all. Welcome, Manoj, to the evening.
Thank you. Thank you.
I'd also like to introduce Dr. Rajiv Punjabi. Rajiv Punjabi is a gynecologist. He's a laparoscopic gynecologist who has an immense passion for ultrasound and gynac and antenatal work with pregnant patients. In 2003, he, along with one of his batchmates from Sion Hospital, Dr. Sheetal Sabharwal, had set up Tulip Healthcare, which is a dedicated gynac and obs unit in Khar, Mumbai. And he's also pioneered water birth in India. And he continues his passion for water birth and ultrasounds and laparoscopy. And in fact, Rajiv and I have been working together, partnering each other in laparoscopic work for the last 20 odd years. And well, he's my backbone, if I can actually put it that way, and a brother. He also practices at Hinduja Khar and Beach Candy and Elizabeth and Sushusha for patients who he doesn't see in his own place. Rajiv, thanks for being here with us.
Thank you. Thank you. My pleasure.
Vidya, could you introduce Dr. Indoria?
Yeah. Thank you, Gautam. So I am really pleased to introduce Dr. Indoria, who is not only very busy, but very senior and leading practitioner. Like a physician, he has his own nursing home in Thane last almost more than 2 decades, if I am not wrong. In addition to his academic degrees and excellence, he has got a LLB degree also from the Bedecker College. So he has given many talks on medical legal topics in various conferences. So welcome, Dr. Sushil. It's great pleasure to have you here.
Thank you.
Gaurav,
Payment possible now also.
So great. Can I request everybody who's joined us to please mute yourself so there's no disturbance, because these recordings are going to go on YouTube as well. So amongst the audience, anyone, if you can mute yourself, it would be great. So can I start this session with Manoj? Manoj, I'm going to throw the question to you. More importantly, because I forgot to also mention that Manoj has been the secretary of the Bombay Nursing Home Association. So he's probably also dealt with multiple of these issues on a legal level. So Manoj, I'm going to throw this on to you first. I'm going to ask you to share your insights on the current challenges that are faced by small hospitals and nursing homes in India, particularly in the context of providing healthcare services in the urban setting.
First of all, when we compare small hospitals and major hospitals, there's a huge difference in the patient's expectations in the government licensing agencies, as well as the health insurance companies, how they approach the smaller hospitals. So we are always going to be at the bottom currently in the entire scenario, although we are providing them more than 60 to 70% of the healthcare. I have been on the forefront of this battle with the health insurance companies, with the licensing agencies for last 15 odd years. And in last 15 odd years with the licensing agencies, 5 commissioners have changed, but we are surviving. So I've met all the 5 commissioners till date for various issues for small hospitals. There are multiple licenses required. I've got an entire list which is required for hospitals, whether it is a small hospital or a major hospital. And each license, we have been struggling to get under one roof, one window approach for a long time in Bombay at least. But we've not been able to achieve that. The only achievement were 2 important achievements primarily by Bombay Nursing Home Association. One achievement was getting our renewals shifted of our C from 1 year to 3 years licensing. So that reduced our efforts to get our C forms. So there are many hospitals, in fact, across Bombay, everybody benefited with that decision. And now that C form procedure has become pretty smooth. I have gone on to the extent where the mistakes that the software was creating with the MCGM for uploading documents, we've given them the insights into it at the inception and got those things sorted out. The second issue was the fire in Bombay, at least. In Bombay, Thana is different ball game again. Bombay, we had the issue again, every fire officer was asking for a bribe. I had to break my head to tell all our colleagues, please do not pay a bribe. But unfortunately, I used to get calls that Manoj, मैंने तो 4 लाख रुपया निकाल के रखा है उसको bribe देने के लिए. But मैं Bombay Nursing Home Association का member नहीं बनूंगा, जिसका फीस सिर्फ 4,500 है. So these are our own colleagues, our own fraternity, which are ready to shell out any kind of money. To be very honest, if you have everything systematically in place in your own nursing home, then you don't have to pay a single pie of bribe. What we are doing is that we are buying properties which were not justified, which were old properties, and which were difficult to manage them as nursing homes. Then we were facing those issues. But currently, the newer setups, they have to fall into line with all the protocols as far as the building proposal department is concerned, fire NOC is concerned. Those waivers have been only for old setups currently. But still they are demanding that, for fire, you need a separate staircase. And to waive off that separate staircase, the bribes are asked up to 3 lakh, 4 lakh. So what everybody feels is that, चलो ये nursing home पैसा कमा रहा है, biomedical waste वाला भी उसको थोड़ा charge करेगा, color code वाला भी coding के लिए थोड़ा charge करेगा. Then you'll have these practos, librates, they'll say we'll take a little pie out of it. So everybody feels that hospitals are making money, let us take some pie out of it in whichever way they can. But honestly believe you can still work on the same systems with your simple tally, with your simple Excel, and manage your nursing home very well. If you tell me today, I can give you my first patient data right from 2004 till today. at a click of a button. So if you're tech savvy with your Excel, with your Tally, then you can, you don't need those systems in place. But there are going to be with AI now, recently with ECG machines, they are all AI generated reports. So the cardiologist, it's out straight away from the nursing home. Earlier, the nursing home had to, run after the physician to get that ECG reported in case of an emergency, if that nursing home is not managed by a physician. So those things used to be difficult. Visiting consultants to a nursing home is again a problem. I'll give you a very simple example. I had a lab chole patient who required 6 various specialties opinions before he being declared fit for a surgery. Patient seen by me in my nursing home at 9 o'clock. I told him, this is 6 opinions, nephro, cardiac, diabetic, physician, all those opinions. I don't think I can manage you over here. Let us go to a major hospital. I'll operate you over there. 10 o'clock patient reaches the corporate hospital. All 6 opinions done by 12 o'clock and I operated the patient next day. But that same thing, if I have to call 6 consultants at my own nursing home, it will take me 2-3 days at least to work them up. So the approach by our own fatality, although everybody has started small, are different when they approach a smaller hospital and a corporate hospital. Sometimes the smaller hospitals pay better also for those visit fees than the corporate hospitals where we keep on seeing patients in the lower class at lower rates. But if we give better rates also, we find difficult. And that everybody has a lot of expectation from smaller hospitals. Agreed, everybody wants money, everybody needs to be paid. But then we are all team, we are consultant colleagues. So everybody's pockets have to be taken care of and which is justified to be done. You cannot have a difference of approach in how you approach a smaller hospital, how you approach a charitable hospital, and how you approach a corporate hospital. Everybody has difference in approach. If I have a neurosurgeon required for at least an opinion in my nursing home, it will take me, contacting at least 5 people with my good contacts and then one of them will turn up. But if I have to do that same in a corporate hospital, it's not difficult for me. Same way the health insurance. Health insurance are not giving us the rates in spite of we being NABH. NABH is another ball game which takes away a little money out of our hospitals. Although we are in system, we have all patient feedbacks. My hospital is ISO certified for 10 years, NABH certified for 6 years, and I've been taking feedback from my patients for a long time. What NABH has done, nothing new for me. In spite of that, I have done the NABH accreditation. It's a waste of time. The people who are not systematic, to bring them in system, NABH is good. But people who are already in system, it's a waste of time for them. There is no added advantage. The insurance company doesn't give you the rates. It doesn't increase the footfall to your hospital. I'm sure gone are the days when you used to put a board of FRCS or an MRCS and you used to have a UK returned, France returned, and probably people used to admire those certificates. Now, I've got not a single certificate even of my degree displayed in my nursing home for last 20 years. I don't want to show them my degrees. Whoever wants can go to my website, see my certifications, and that's fine. But there is not a single. So, you can manage your nursing home, hospital in the same corporate style, in a smaller way, where you can treat your secondary care can be very nicely provided in all the smaller hospitals. You don't want a malaria patient to be admitted in a corporate hospital. But today's generation, see, we have shifted from a pattern where we had old and senior patients coming to us and expecting them to be better, and they used to believe in us, they used to trust in us. And the current generation are Google literate, they have everything on their fingertips, and they would want to expect a moon from the smaller hospital, which is not possible nowadays. So you have to put down your foot. Okay, this is possible in my hospital, small hospital, and this is not possible. So licensing, health insurance, if all these things are taken care of, I think there is enough for the small hospital to survive today. The big hospitals are behind our back for shutting us down. Post-COVID, 30 of our members have closed their nursing homes. So 1 bed to 15 bed. My current point is that 1 bed to 15 bed, you need at least 2 consultants within your team members to run that setup effectively, at least. But if you have a 40 to 50 bedded hospital, then running it becomes a little better than a 1 to 10 bed or 1 to 15 bed. So single individual owned nursing homes are going on the way out. It is practically impossible. I sit over here every day till my night staff comes on duty properly on time. Then only I can go home and sleep peacefully. And I'm a one-man show for last 20 years. So this is my take on, but I'm survived. So it's not that small hospitals cannot survive. We can beautifully survive. The licensing agencies create a whole lot of a problem with us. But if our own community is united, then believe me, we can dictate terms to the health insurance companies, 101%. But we are not united is our problem. Gautam, you are mute.
I liked what you put in is basically the approach to nursing homes from all factors is basically different, including doctors, including patients, including the admin and everything. I guess, yep. I think it's an important point for us to look at.
Yeah, I would just like to add one more, like there are, as you said, there are a lot of difficulties, but finally we shouldn't forget that, we give good quality care even in small hospitals and to majority of people, you can say, not all of people go to corporate hospitals, there is a select class which would want a brand or a corporate hospital. Otherwise, most of the people do come to nursing homes. And actually, I being a physician, what difficulties you said, mostly the physicians don't face it because, they can manage the show. And, we have contemporaries coming in and, that way we can manage the consultants coming in also. Like I have most of the consultants visiting my hospital. So even before I see the patient, many a times the cardiologist has already come and seen the case, or a neurologist has already come and seen the case. So it might be different for surgeons and physicians, but then that's not a major issue. I think it can be managed as long as the patient gets a quality care
I have been
and a
managing.
personalized care. I would say
I
personal.
have been managing, madam. For each specialty, I've got at least 2 or 3 people coming to my hospital. I've got almost 20 anesthetists coming to my hospital. So it's not that it cannot be managed, but the approach is by our own faculty is different towards the smaller hospitals, which should change because everybody has started small. Nobody has gone and got an attachment today on day one to a corporate hospital and become a big consultant. We all have started with small clinics, small nursing homes, and then migrated towards being, head of departments in major corporate hospitals or head of units or being a big consultant in a big hospital. So everybody should understand that we are still small and we can grow big from that small hospital.
Perfect. So we take the next question. Let's take the next question here. So can I direct this to Rajiv? Rajiv, how do you see the role of small hospitals evolving in the changing landscape of the Indian healthcare system? Now, just focus this thing with the technology and patient-centered care that we look at in a nursing home.
Yeah, thanks. So Manoj has pretty much done a very broad approach to many of the issues that we face being. Sorry. So Manoj has basically covered in brief most of the issues. I just want to clarify one or two things before your specific question. One is that we can't generalize. The moment we say small nursing home, like he said, up to 15-20 beds, then there is a mid-level hospital, 20 to 50, 60 beds, and then there are more than 70-80 bed hospitals, and then there are tertiary hospitals. So there are actually 4 categories. One peculiar thing which Manoj didn't touch on is that healthcare is also becoming very area specific, especially in cities like ours. I'll give you an example. I run a 15-bed nursing home in an area where over the last 15 years, we have had 4 new corporate hospitals. When I travel a little further into the western suburbs, that's not the case. Beyond Andheri, the number of tertiary large corporates is very less. So on that side, the 20 bed hospitals are still doing probably 80% of healthcare, and their role is absolutely irreplaceable as of today. Compare that to us, where we are sitting in an area like Bandra Khar, we are completely replaced, because not just simply of affordability, but because there is that much more options available for people. Insurance is a very, very important factor, because today, at least in our practice, we see the penetration of insurance in the educated classes, in the better class of society, going up to almost 70-80%. This is very different throughout the country. I agree with that. In the country, insurance penetration is very minimal. But I'm giving you the perspective from cities, from metropolitan, because you said urban areas. So in metropolitan areas, insurance penetration is taking away work from the very small nursing homes, because every patient who can have a cashless insurance at a larger hospital, even if he knows that the bill will be much more, and if the insurance company is paying, he prefers now going to a larger hospital because of whatever reasons. Let's not go there. I think one of the reasons is also that smaller nursing homes over the years have not managed to put in back the amount of investment that they used to put in earlier. So somewhere we are in a little bit of a circle where incomes go down, so we don't spend on infrastructure. If you don't spend on infrastructure, incomes go still further down. So it's always going to be who came, what came first, chicken or egg story. Now, coming specifically to your question, what can we do and how do we evolve with times and move forward with it? So yes, we can. I agree with Manoj. We can manage with things like Excel and Tally and single man job and all that. But let's face it, we are all right now meeting on Zoom. This is also technology. We are sitting so far away from each other all over the country, and we are meeting. So we can't not embrace tech, because I don't have the volumes and the income, whatever the nursing home is doing. I can't say that I will not embrace tech. Hospital management softwares, clinic management softwares are becoming now randomly easily available. Yes, it requires a level of training, it requires a level of cost, but it's mandatory. We have to move that way. Like Manoj himself said, all his records are digital. So whether you do digital with basics, or you do digital with one software, not embracing tech is not an option for us. We are embracing tech in every single way. We are embracing tech in surgery also. No, at the end of the day, we have to keep upgrading our equipment, whether the volumes of business are generated to that extent or not, because it's a vicious cycle. If I don't upgrade my equipment, then I cannot provide the services. If I upgrade my equipment, I can provide those services, and somewhere I have to figure out the cost, and the cost will come out from the services themselves. So embracing tech, whether it is going completely digital with our records, whether it is making patient interactions more and more digital, SMS reminders of appointments on a software system. I'm not saying that everything should be online, but even when somebody calls the clinic, my staff has to go into a software to give appointments. She has to be able to remind those patients of their appointments. Discharge cards, indoor papers, OT notes, everything now has to eventually move to going digital, and people are doing it. I mean, even the 30-40 bed places that I visit now are making me write my daily notes on tabs, so it's coming, and I think it's a good change, and I think it's a sign of the times. That's as far as the tech is concerned. As far as the other issue, I think you spoke about, Gautam, what was the second point? Sorry, you're on mute, Gautam. Gautam, you're on mute.
Basically talking about your role in improving in terms of tech and patient-centered care.
In terms of patient-centered care. Now, Dr. Vidya made a very valid point, personalized attention. Now, I'm a gynecologist. So there's innumerable number of times when the patient has a clear choice between being one of many in a corporate hospital, one floor of obstetrics, or whether she wants personalized attention in a smaller setup, which is essentially OBGYN. At least in my field, that still gives us significant advantage sometimes in some category of patients, where they want to be in a smaller setup, where the staff are more capable of looking after them on an individual level. So that patient-centric approach of ours in for example, obstetrics or post-surgery care is still going to be very advantageous for us, and we have to hold on to that. We have to keep upgrading on that, because it's not that tertiary hospitals don't look after our patients. I am attached to three tertiary hospitals now, and yes, there is fantastic nursing and care there also. But it is always going to be that you are one of many, and the nurse to the patient ratio is not going to be like a small setup. So that advantage of reaching out to patients and giving them personalized care is something which we have to very strongly hold on to, being in small institutions. And I personally see that in very small setups, that is sometimes now getting neglected by many of our colleagues. And one of the issues is that we're not getting staff. We're not getting trained staff. Licenses are saying that we need to have trained staff. NABH is saying we need to have trained staff. Frankly speaking, in an area like Bandra, I'm telling you, for me to get a GNM or a degree holding staff nurse, we need to pay them 40-50,000 bucks, 35,000 bucks. We don't afford that kind of staff. We can't even have people working for that much, because in corporate jobs, they have other securities. They have so many other benefits they are given. So without trained staff, the second best option is to train the staff that you have. So whether it's AMC nursing home cell, whether it's BNHA, everybody is doing nursing training programs. We are trying our best to skill the people that are available to us. That's the second best option. There are issues there because authorities don't accept that if you have skilled, untrained people, it is enough. They still want you to show licenses. But there is a middle path. The middle path is that if you have people who have done even certificate and diploma courses and you upskill them, at least the patient is going to be looked after well. Of course, you need to look after the legalities. You will have to have one trained staff at least to look after the other untrained ones. But you need to constantly upskill your staff, and only then are you going to be able to satisfy those patients who are still wanting to come to a nursing home. I agree with Manoj and Vidya. There is still lots of patients who want to come to smaller setups. They want to come to us because they understand we are better at individualizing and personalizing care. They understand that here they are a little more VIP than in a corporate hospital. They also understand that costs are lower, whether they are self-paying or insurance. There is definitely a huge difference in costs. The point is, how do we hold on to these people? And I think embracing digitalization, upskilling our staff constantly upgrading basic infrastructure. If we have those old rundown rooms with those rundown toilets, that image of a nursing home has been built up over the years in some places. That has to be broken by us. If we do that, then we have a right to talk about the other issues. If we let that go, then as Manoj said, it's only a matter of time before the smaller places will eventually shut down. In 23 years that I have run a nursing home in Bandra, 16 have shut down and not one new one has opened. And I don't see any sense in any more opening in an area like that, where you have 4 corporate hospitals and 3 mid-level hospitals in the same area. But again, this is Bandra. I know that the world is much, much, much bigger, and small nursing homes and small healthcare facilities are still catering to 70% of healthcare. And my request to all those people running such places is focus on upgrading constantly, focus on upskilling. You need to sensitize your staff. Staff needs to be trained in today's patient care. They need to have that little bit of, we have social media. It takes one Google review to ruin your whole reputation. These are facts. We can't run away from them. I'm not saying that you have to be scared of that. I'm saying you got to take preventive steps. From the time a patient enters a nursing home, her interaction with the receptionist, with the staff, with the 4th class employees, with the mamas, with the maushis, everything is going to be Google reviewed at some point. And ask yourselves, how many, if you are somebody who asks every new patient who referred you to me, you will realize how many of them are coming only by internet reviews. At least in a large part of cities like ours, patients are reading about you before they are coming to you. So it makes a difference with what conclusion they leave your place. If they leave with a smile, they are going to give you that one thumbs up. If they leave very upset about either personal interactions or, I was billed 1 lakh when I was quoted 50,000 and nobody could explain to me why the bill was more, or these people are not ready to spend on basics, the toilets are dirty, there is leakage everywhere. If that kind of an interaction, the patient will leave, then I think we are only looking at the end eventually of all smaller setups. Because these problems exist in larger hospitals also. But there is a natural tendency of human beings and patients that when it's a larger setup and there is nobody to complain to, they don't complain. In a smaller setup, they know that the doctor who owns the place is sitting there. They can walk in, tell him this is absolute nonsense and walk out. Face it, we need to upgrade, we need to upskill, we need to improve our interaction with patients. We are all fantastic clinicians, but that's not enough. We are fantastic surgeons and gynecologists, but that's not enough. If we have to provide an edge to hold on to these patients, then that edge can come from that personalized attention, and we need to move with the times. I think that's it.
Rajiv, that's actually completing everything that Manoj may have partially missed out here, but I'll probably run a few more questions. Anything you want to ask, Vidya?
Yeah, no, he's rightly said you need to upgrade yourself, you need to train your staff, and yes, there are patients who will go away happily from nursing home also. So it's there, it is a required, it is a need of the hour along with the digital upgradation. So we go to the next question.
Yeah, sure.
Yeah, so I would just
So
like
let's
to,
take your opinion on it, Dr. Sushi. Please ask him.
yeah. So Dr. Sushil, I would just like to ask you, like, same, what are the key advantages of the small hospitals in terms of healthcare delivery? Again, a personalized care, what we are discussing here, and a community engagement when you compare it with a larger hospitals. So could you throw some light on this?
Sure. Thanks for first inviting me. It's a beautiful program. UMANG is good. I have just gone through all the videos previously Gauri has sent me. Second thing is, I think Dr. Manoj and Dr. Rajiv has more or less covered up the problems which are cropping up in nursing homes. I think everything starting from staffs and consultants, and I think Manoj is very right about so many doctors. They will go to corporate hospitals very easily if they are called for and proper time also. But when you call in a small nursing homes, they take their own time in spite of we paying them properly. So I think those issues are there, but sometimes I think everybody understands we can actually go smoothly ahead. I will be very specific, like again, because we can surely talk about a lot of things in question answer sessions also. See, we are like a secondary healthcare. General practitioners are like primary healthcare. We are the secondary healthcare, and then we bridge between the primary and the corporate and tertiary care health centers. And we have got a good role. So I won't say that small nursing homes are going to be go away from anywhere. But yeah, given opportunity, as Dr. Rajiv sir has said, in Bandra and Khar areas, a lot of corporate hospitals have come up. So naturally, the consultant have got a choice of going to the corporate hospital and maybe shutting down the small nursing homes. Because nowadays, to get a staff and especially consultant and RMOs, because so many times you just can't leave your patient in the hand of RMOs and the staffs. So our role continues to be there in a small nursing home. But in going to suburbs area, like somewhere you can say behind Andheri and here behind Ghatkopar, a lot of small nursing homes are there, and I think they are going to be there. But only thing is possibly the very small nursing homes may not be there. They'll be categorized below 15, 20 beds. Now we see a lot of hospitals coming above 20 beds hospitals. And so they are going to be having a bridge between the two. Now, getting a personalized care to the patient, naturally, we have a very better role. Uh, we know in corporate hospital, the family physician type of practice is not there much. There are a lot of talking about all those how to go about surgeries, charges, and all this thing. But here in a small nursing home, we do talk to the patient. We do really give them what are the benefits regarding the charges, regarding how the surgeries will be done, and possibly most of the time we are there around the patients here. So they feel like the patient, the doctors is there for us. So a personalized care is much better when we compare with the corporate hospitals here. Naturally, they get the best service. And very rightly, Dr. Rajiv has said we have to upgrade our hospitals, and that is the need of the hour. If I tell you long back, like I'm practicing from 1993, There were hardly any nursing homes in Thana where we used to have ventilators and other central monitoring systems. A lot of things were not available at that time, and there was only one big hospital like Singhani Hospital used to be there. Now, over the years, in the last 15 years, we are seeing most of the hospitals, nearly 70% hospitals have upgraded themselves to have this ventilator, central monitoring system, better monitoring facilities, even a small nursing home. So the changes are going on. Like previously, I remember like we used to write only on the papers. There was hardly any digital there. Now, very rightly said, now we have a tabs like, and everything is written on the tab. So the documentation is there. Your MRD system is becoming better and better compared to what we used to practice 2 decades back. Even your OPD digitization is happening, as very rightly again said by Dr. Rajiv. Everything is being, and you have to maintain those records. Because if you go by MRD, if these records are not maintained, and nowadays it is not only 3 years, we have to maintain records for more than 7 to 10 years. And medical legal, so you have to keep it records for long back. Like I just got a call, and the patient in 2010, he had a case for MLC case, and I had to get the papers in 2010, and that time we didn't have any records, keeping all these records. To get those papers, it will be difficult. But now, luckily with these tabs, we know that at least for next 20 years, we can keep those records with us. And anytime through the cloud, we can get back the records and submit to the PC. So, and compared to the community engagement at a lower level, we are more in contact with all those general public. I know we don't like politicians, but naturally they do help us also. If you have got a good rapport with them, they will surely help you in that crisis. And at least in Thane area, we have got good rapport with all those politicians. That is in my area, I know all my Nagar Sevaks and corporators. So whenever there's any medical camps or whenever they ask for any favors, we are there with them. So coming to the community part also, we are actively, like the small nursing homes can surely come in contact with the small people. They may create a ruckus, they may come to your hospital, but if you got a good rapport, you can surely diffuse those situations in a better way. And we also, as a doctors come to small nursing homes, we have come together here. We have got a lot of organization in Thane area, like College Jan Baksha, and even our IMA groups and TDMP groups are quite active. So whenever we have a problem facing during any patient getting critical, all those doctors are there within 5 minutes, 10 minutes, nearby doctors, and try to diffuse the situation. Even we also have a good rapport. See, as a small nursing home, you have to have good rapport with even your police persons also. So maybe in near police station, you just have a meet with your CDR PI and just meet them and have this thing. I know sometimes you feel silly. So many people may feel, why are we doing all those small things and meeting them, and like in simple word we say, na chaatne ka kaam tu karna hai. But it is not the way, I tell you, because it's like we are a small nursing home and you can face a problem anytime in your practice. You are not genius here, and you are possibly your staff may do a mistake, and anyhow vicariously you are liable to those things. You just can't say I was not there and my staff has made the mistake. So you have to face all those things. So all those rapports will help you out whenever you have a problem. And again, very rightly said, Dr. Ajit, to get the staffs is very difficult, and it's a universal problem for small nursing homes. And even if you get it, then paying that much amount is too much. But then you have to increase your cost of treatment, which sometimes the patient may not be able to afford. And we do get a lot of middle class, lower middle class population who can't afford going to the corporates. So on those patients, we have to treat them. So all those personalized care and community comes in our
Yes,
picture.
very rightly said, Dr. Sushil. And just I would like to add, we just like we have in Thane, we do still have a rapid team or rapid task force, wherein if any hospital is vandalized or it's facing a violence, the team gets into action immediately, and that's how it gets diffused. And obviously, rapport with politician is very important. So that's a very good point you have put in. Gautam, would you take it further? Yeah.
Manoj, I'm going to put the next question to you. I think this is wonderful coverage of what you had as in terms of this, Sushil. I'm going to put this to Manoj now. Manoj, what now with Rajiv telling us about the number of nursing homes that have closed in his area and everything, what factors do you think are critical in contributing to the success and sustainability of a small hospital? You'll need to unmute. Manoj, you need to unmute.
As Dr. Punjabi has told that there are few things which we need to follow if we have to sustain our hospitals. One is constant gradual upgradation to the current level of care as far as the equipments are concerned and as far as technology is concerned. That is number one. If you can provide the same level of care that can be provided for secondary care in a major corporate hospital, then definitely all small hospitals can survive. And it is not difficult. The difficult part is the staff. You cannot get the staff which a corporate level will get and will pay. So what I do different in my own hospital is that I constantly, every 1 month, I take all my staff in my small consulting room, sit with them down, hear their problems out in managing the patients, and constantly train them to upgradation, as well as allow them to do constantly training programs where they will get trained on either online or in person, so that there's a constant cycle. And I've been doing this for last 20 years. We've also conducted nurses training programs also through the association. So if you don't train your staff, you may have an A&M staff, she need not be a GNM staff, but I'll tell you, most of my staff, they do all the vein flows, Foley's catheterization, Ryle's tube insertion. In fact, I've got a ward boy who does all the dressings, colostomy bag changes. They were all 10th, 12th pass, and I've got them to this level where they are doing most of my work. In fact, by the time I reach the hospital, they have already send me all the vitals on WhatsApp, patient's wound pictures, if there's an infection or something like that. They would constantly keep me. So if I don't teach them the technology, if I don't upgrade them, then how do I provide them the care that a major corporate hospital will provide? So these are the two things which are primarily important. And the third thing is, currently with this cashless everywhere, see, we have been squeezed totally by the insurance companies, and I have had big battles with them. I somehow have managed to get rates and be on panel of some of the insurance companies. I don't do all the insurance companies' work. I am totally against empanelment with GIPSA, which I have tried to tell to all the associations to come together and let us say that we are not going to do any GIPSA patients, because that is one big cartel which has squeezed down the smaller hospitals' income. Once upon a time, when I had these patients coming to my hospital, every time I never had any money flow problem. Now also I don't have, but the issue is not that. Now we are being squeezed and all these GIPSA patients are going to all the corporate hospitals. There are very few private setups which are accepting the GIPSA patient, which is a major chunk of insurance. So if we try to get better rates from them, if we can get or negotiate, or we unitedly tell, see, they are breaking nursing homes and corporate hospitals. So we have to come forward together as small hospitals and tell them that we are not going to accept your rates, which are rock bottom. Imagine they are giving my hospital for lab coli of 45,000 package, all inclusive, and the same package, and that too in Prabhadevi. That same package in a nearby hospital is up to 1.5. Now, if I have to charge only 45 to a patient, in which includes 10,000 for medicines, 10,000 for investigation, what do I pay to the visiting anesthetist, assistant surgeon, anesthetist, and then there will be a fight between the consultant कि मैं इधर गया मेरे को इतना ही दिया उधर गया उतना ही दिया. So that is going to be a constant battle, and we will never be able to have the faith of our visiting consultants. So we either put our foot down and say that these are our standard charges as per the market scenario. If the insurance company is accepting, well and good, you go and give them the cashless services, or you say no. Remember one thing, we are the focal point between the insurance company, the patient, and the hospital. It is we who are giving the credit to the insurance company. Tell me how many of us get credit for all the things that we do in our life, unless there is a loan. We do not get credit from anything that we buy in the market. Agreed, healthcare is different, but we are giving the credit to the insurance company, and insurance company is running a business. So they have made us as small healthcare business providers. So we have to actually be united. If we can unite, at least within Bombay and Thana, and put our foot down, I'm sure all the insurance companies will at least come forward for discussion. I'm not saying that we have to give them the rates as big high as the corporate hospitals. But their take is that lab colleague with adequate infrastructure in a smaller hospital should be paid less, but a lab colleague in a corporate hospital, sometimes with lack of infrastructure for recording or some equipment not working, but can be paid 1.5 lakh. So I am seeing both the sides of the coin, since I operated corporate hospitals also and I operated my hospital also. So we have to, as small hospitals, to survive, balance all these 3-4 things, and then I don't think it should be a problem. Half of your administrative work should be delegated to your secretarial staff and all. If you are a single person or you are 2 people, you cannot do all the administrative work anymore in the hospital if you have to concentrate on your medical care.
Manoj, thanks very much for putting that thing down. And I think we understand where you're able to create survival for yourself. One is we have to embrace insurance partly, but try and find a fair approach to it. Rajiv, I'm going to ask you one more question. You did speak about embracing technology in your last thing. Can you just tell me how would you recommend in specific ways of how you can leverage yourself by, embracing this technology? And how do you plan to do that as a small hospital? Whether it's digital telecommunication, whether it's digital marketing, whatever. Just can you tell us how you would like to do that?
Sure. So, like I said, I mean, the internet has changed everything. Some of us don't understand or don't want to believe that our patients are far more well-read, aware, and intelligent than they used to be, or than we want them to be, or than what we accept that they are. But facts say it otherwise. If you read enough data and you read statistics, you will realize that, like I said, these are not wild figures when I'm saying that most patients know about you before they see you. I was reading some of the chats, and some of the comments from the people who are attending this meeting are really interesting. Somebody said that patients now are not necessarily looking for a consultant. They are looking for a cashless facility. And yes, we've all experienced that. That's a fact. There are people who come to me saying, listen, we need a hysterectomy. We've gone through everything. The basics are done. We have a cashless with this insurance, and we want to do it in this hospital. Will you do it? So it's all done. It's all there. I have to just go and do it for them in that much rate. And if I agree to do it for example, in a GIPSA rate, there are some nursing homes, some smaller hospitals which told me for a hysterectomy, we'll give the surgeon 15,000 rupees. In a tertiary hospital, I charge 75,000 rupees surgeon charge. So obviously these issues we all know. My point is, let's not go into trust and faith and the lack of it. When we talk about how patient and doctors relationships have changed and gone down, let's face it, this is society. We are all part of it. Human beings have changed. Loyalty, trust, faith, all that is superb till you're doing the correct job and the right job and things are going well. When things stop going well, then you are the villain, and then there is no faith and there is no trust and loyalty. So if I have delivered 3 generations, doesn't mean that the 3rd generation, 4th generation will come to me. Those days are gone. Let's wake up. Let's accept reality. We want to be nice. We don't want to be God. Anytime somebody tells me, oh, you're God, my first answer is, please, let's stop this conversation here. I don't want to play God, because it's very sad then when things get complicated, and which they will, in any surgeon's hands, we will have complications. Then we become villains. So let's leave that path aside and let's come and get real. We are in an information highway. We are in a digital world. We are in a world where if you give a fancy diagnosis, chances are in the next 15 minutes, the patient will read at least half of that from the internet. And you have to be careful what you are saying. Those days are gone where you could give a patient a diagnosis and say, it is this, and this is the only way forward. They'll come back to me at the next consultation and say, but I read that there are 4 other treatment options. Why are you not giving me those options? Let's start accepting this. First of all, I think acceptance from our side is slightly short. There are many doctors who still think they're living in a very closed environment where my patients don't read so much. When I was at a roundtable conference about the Gardasil vaccine, I'll just give you a very quick example. 10 years back, there was one gynecologist who said, the panelist was asked, how much, what do you think is the age of onset of sexual intercourse in boys and girls in India? So at what age should we start giving the cervical cancer vaccine? So everybody said 18, 19, 20. I said, you need to come down. If the vaccine is approved from age 9, start giving it at age 10 and 11. So I was laughed at. This was 10 years back. I was laughed at. They said, oh, you're in Bandra, so you must be seeing that kind of patient. I said, please get real. And then I presented statistics to them. There was a study at that time done in tier 2 and 3 cities of this country, which showed that age of voluntary beginning of intercourse, voluntary intercourse, in boys and girls in tier 2 and tier 3 cities. In girls, it was 14, and in boys, it was 15. So what are we talking about? Let's get real. Let's look around us. It is a day and age of information and internet. How can we leverage that is the next question. The question is, do we have very large budgets to market ourselves? The answer is no, at least not in small healthcare setups. But should we ignore it completely? No, that would be asking for our own death and our own last nail in the coffin. So at some level on our own, we need to have a little social presence. We have a small little poster that is put up in 3-4 places in our clinic and nursing home saying, spread the cheer. If you were happy with us, just leave a thumbs up on Google. And in 1 month of putting up that poster, we suddenly realized that we went up from 20 reviews to 40, 50 reviews. Because we realized that we have catered to thousands of patients over the last 5-7 years. But we never told them that go and review us on Google. And then we saw other hospitals in the area who have opened 5 years back and they've got 5,000 reviews, 10,000 reviews. Of course, I know that some of those are fake and I know that's paid for. But tell me, what is the harm in your 1,000 patients in 2-3 years giving you one little 5-star or 4-star on a review or writing 2 nice lines about her experience? There will be bad reviews also. But I'm sure that in your practice, overwhelmingly 99% of us have patients, more patients who are happy with us than who are not. That's a fact. And I think for every Indian doctor, that is a fact that will never change. I'm very proud of Indian doctors. I think we do some of the best job in the world. And we have people who are happy with us. We need to leverage that. We need to go back straight in their face and tell them, listen, you're happy now. So let other people know. The same Google review which you read before coming to me, if you add to it, it will make another person benefit from my good work. So one thing is about your own self-promotion to some extent. For many years, we thought that we are not the types to show off, Let's be honest, it's not about showing off. It is about asking people to appreciate what you and me are doing good, and there's no harm in asking for that. At the hospital and nursing home level, yes, if you have a budget, you can hire somebody to do a little more marketing. But I know a lot of individual doctors who take a little time from their practice and they make Instagram reels, they make Google videos, informational videos on topics of which you enjoy. I'm not saying everybody should operate live on Facebook, but you can have basic topics which you enjoy talking about. Here I am talking on this Zoom meeting. I can spend 10 minutes talking about basic idea about what you should know about fibroids and upload it on YouTube. You will be surprised how many people are reading this stuff. So at the basic level, this is one way to leverage a little digitalization for yourself. At the nursing home level, I think it's very important what Manoj said. You need to constantly upskill your staff. You need to make them also a little tech savvy. My staff never knew how to use a bloody mobile phone. Today, they can give appointments digitally. They have a WhatsApp number of the clinic where they are communicating with patients, nothing official, but they at least communicate. If a patient says, I can't get through to Dr. Ajit, please share this report. They can communicate. We need to do that. How many of our staff are actually doing that for us? We need to be able to tell a patient that in an emergency, you can reach out to us in multiple ways, including online. It's not just about giving appointments. Simple things like I do a pap smear and the report is gone, is not going to come, hard copy is not going to come for 10 days. The soft copy can come and we can share that soft copy on a proper platform with the patient. Take an email ID. Don't do a WhatsApp. Take an email ID. Send the email to the patient and tell her, pick up the hard copy at your convenience. You have no idea how much these small things matter nowadays to people. They matter. The question is, are we ready to understand and accept that? Do it. It will improve your digital presence. It will improve your image. And before you know it, you will have just a set of patients who are coming to you only because they have heard of you on this very large internet platform. There are a lot of downsides. If you are basically doing very bad practice and you're a rude person and you're not giving proper patient care, then you're going to face the music online. But I think most of us, at least, like I said, I have great faith in Indian doctors. I think we are doing fantastic jobs. The time today is to shout out loud that I'm doing work. I have patients who are happy, and tell those patients, go shout out to 10 more and tell them you're happy with us. So we got to get in a little more personalized, Gautam. Yes, if you have more money and you have more marketing budgets, then go ahead, splurge on a marketing team, make brochures, make online content, start reaching out to communities. You can do, Dr. Sushil said, I thought his idea about outreach with local authorities, whether it is police, whether it is government, whether it is political parties, Shakha Pramukhs, these guys do, whether we like it or not, they have a government out, they have a certain outreach in the community. And that community outreach can be leveraged by us. They can take us into the community. I've just got a small little 30-40 bed hospital opened outside my house very recently. And I joined them and they said, our marketing team will go to every residential society in the area and offer consultation camps on Sundays. So you got to do this. You got to do this. You got to reach out to the community. And that's the only way that, see, we are thousands and thousands of consultants. We are all doing a fantastic job. The patient out there needs to know that you're doing a good job. So the onus sometimes is on us to reach out to people. We can't, those days are gone where I sit in my clinic and I say, oh, if I'm good, people will come to me. And those days are gone. That's it. Thanks.
I would just like to add one small thing, that I have followed a practice of taking the mobile number and email addresses of all my patients. So the patients who definitely, maybe 90% or 95% who are pretty happy with my services, 2, 3, I can't say that they may always be happy, but I'm sure 95 or 98% are happy. So I make it a point to tell my secretary, send them a Google review link and reminder to fill up that Google review link. And that adds to your Google review. Today I had a MLA's patient admitted at my hospital. He's a Nepali. He came yesterday and today he's telling, sir, मैं चुनावटी से आने के पहले आपका सब Google review पढ़ के आया. So, you just can't avoid technology today. Whatever platform you use, online consultation, Google review, you have to be on the online platforms. You like it or you don't like it.
Yeah, those were really great insights and thoughts. And actually, in addition to digitalization, now taking it further, as you said, we need to have a trained staff. So, Dr. Indoria, I would just like to ask, in the current era of high attrition rate, people switching the jobs, every now and then, especially the nurses and the ward boys. So, and the RMOs, especially in nursing homes, you must have experienced, they keep on doing double duties and all. So what do you recommend to, keep them retained with you, and do you have any special suggestions to upgrade the training and retain and attract basically the staff so that, we keep smoothly running?
Very difficult question, you can say, it's very difficult to retain the staff. If anybody next door hospital gives 1,000 rupees more, your staff just runs away. So I think the best way is, first thing is how you behave with your staff. You have to be. What I do, I can just let you know. Keep it like a family affair. We try to, especially I'm talking about those staff nurses and even RMOs. So we try to celebrate their birthdays. We try to celebrate festivals with them. We try to make them important. Okay, you are important for our hospital. And maybe we may not increase the salary every now and then. They may come up to, I keep a very protocol. When I keep them before appointing them as a staff, I tell them your increment will be once in a year only. This is the salary I'm going to give it to you. This is proportionate to whatever the people getting around in our this area, Thane area, or this hospital of around 30 beds. And that is also initial terms condition, you can say a small MOU we make. And we try to see to it that they are there with the hospital. Naturally, if they want to leave it after 6 months, we can't help it out. But most of the time, when we make a good environment around in the hospital, they stick around. And I'm one of the lucky ones. My staffs are there for more than 5 years with me. So, but I think that is how I keep an atmosphere, maybe keep a cordial atmosphere. Now, increasing the efficiency of their this thing. So we have to give them training every you can say 1 month to 2 months. So what I normally do is I take a small topics, especially for nursing people, like how to give IV, how to see thrombophlebitis is there or not, how to take care of catheter, how to take care of this thing, rise to and small procedures which we do in our day-to-day procedures in our hospital. So those trainings are done, and I normally ask them to demonstrate in front of me, something like a small examination like what we used to do in our exams. So those things we do, and if they do a mistakes, it's not like we try to demean them. We try to tell them, okay, you improvise now. Next time, this same mistake should not occur. So similarly, in the RMOs also, normally any procedures are done. Most of the time, what happens, the consultant they are scared, like okay, we should not give it to the RMO. But I stand there and I get the procedure done with them, and they get the confidence. So naturally, when I am not there, at least they will do those procedures without any fear. Because once you get a hands-on experience of doing a central line or putting like this thing, endotracheal tube, or in fact even tracheostomy, my RMOs can do a tracheostomy. So all those things can be done in emergency. So all those trainings are repeatedly done and supervised by us. So that is one thing. And what is the last thing you said? You asked me. Yeah, and enhancing the quality of care. So basically, I think we have been talking about you have to upgrade your hospital every now and then. Like, I have opened a hospital 20 years back, so that doesn't mean I just keep my hospital like that only. So all those things has to be taken care. As Dr. Ravi had said, you or Rajiv had said, you can't have a toilet which is there 20 years back. So you have to renovate. Like maybe every 5-6 years, you have to do some renovation. All those previously, I remember my electrical lines used to be open. Now they're all concealed. So, and even about the medical equipments, you have to upgrade your equipment. You just can't keep your ventilators for 5 years like that only. You have to maybe buy a new one, maybe a better one, buy a newer one. So all those things has to be upgraded. Newer instruments like surgeons, if they think about having a laparoscopy, I remember in 1993 they should do just open surgeries. And over the year now the whole trend has gone away. Open surgeries are hardly done. Everybody does a laparoscopy. So all those things has to be upgraded. Very rightly said, people are ready. People are going to go back. Whatever even medicine I prescribe, I know more 50% of people go out of my OPD. They immediately Google what medicine I have given. They will see the side effect and they'll come back to you inside. Sir, this medicine has got this side effect. This is not to be given like that. And naturally, when they go out to the chemist also, nowadays the chemist also tells them this is medicine for this. And suddenly they'll come back. We know this medicine can be used for 3 other indications. But they will ask you, sir, मेरे को वो problem तो है ही नहीं है. अरे बाबा, the medical store is not a doctor. I have given you a prescription. You have to understand. You have to be very polite and explain them because they are going to read the Google and they have to come back to you. So we have to upgrade ourselves. Naturally, what pharmacology we have read, they are totally gone away. You can have only concepts about pharmacology, but the whole medicines, antibiotics have changed. We have never been taught about amoxicillin and ciprofloxacin. And now we are talking about meropenem and colistins and all those injections, which are not there in our curriculum that time. So whole upgradation of our own knowledge about your hospital, about your staff, and even letting them know how to treat them also, how to talk to the patient, attend the patient regularly. For any small complaints, listen to them, keep your ears and eyes open. Don't just say, "Arey, kuch nahi hai tere ko." Don't do that because that really hurts the patient. They have not come here in the garden to sleep here or just do masti. They have come for some problem. And we have to be sympathetic to them, listen to them, and possibly explain them what is their problem. Some people may irritate you, but possibly as a doctor, you have been taught us to keep calm. Thank you.
Yeah, so you need to be empathetic.
Yes, very, very important.
Can I add one quick point, Gautam?
Yes, sir.
Yeah, sure.
Yes, sir.
Just one quick point. We all spoke about skilling our staff. We all spoke about upgrading infrastructure. I'm going to go out on a limb here and say
Skill yourself.
every one of us needs to look in the mirror and ask ourselves, like Dr. Sushil very candidly said, we learned about amoxicillin, now we are using colistin. How many of us have upgraded our skills without the pharma industry telling us what to use on what are the possible effects of a colistin? I mean, I'm just giving an example that he gave, even surgical skills for that matter. Just upgrading to becoming a laparoscopic surgeon is one thing. But how many of us are really open and actually spend time improving our own clinical skills so that what excellent job we've been doing over the years, it remains relevant for the next 20 years also. I think sometimes, I think the majority of us do it, but there are some of us, I think, and sometimes all of us, we get a little lazy, we go into our comfort zone. So I think we also need to shake us ourselves up every few years and say, come on, I need to learn something new. I need to learn something new. Every patient is a teacher. Every case has taught me something new. And every time I see something new, there's no harm in saying, I learned something today. Go back, read about it, talk to your colleagues, and upskill yourself. If we upskill ourselves, then we can upskill our staff.
Very, very strong
Thanks.
point.
Thanks.
So we're actually running a little short on time, but we don't want to close the session as yet. So I'm going to just direct very pointed questions at some of you. Okay. This question actually is going to go across to all of you all. And let's be very specific on it. Let's not do any generalized stuff that, and embrace technology and stuff, which we all have assumed we are all going to do. My question is, what are some of the best practices or innovative models that you have implemented in your nursing home in the time you've had it? Rajiv, can I put this to you first? Short.
Specifically in what way? In tech?
In tech and not in tech. Anything which is a model which is peculiar to your place, but not an average nursing home. Upskilling, getting tech in, everything. Any different model, innovative model of delivery or whatever it might be. You did some, water birth is probably an innovative model.
Yeah, so I think going back in time, I think we were one of the first obstetric setups who used to celebrate birth. And at that time, nowadays it's very common. I've seen everybody doing it. But we were one of the first few who used to celebrate every birth. We used to make every birth like a party in the hospital. And we would put up, a lot of posters, balloons. We would call a photographer professionally and do on day 3 a nice photo shoot for the mother and the father and the child. And we would make an album and gift it to them, a nice long-term memento. So that was one specific thing that I remember around obstetric births, at least.
Manoj, can I point this question to you now? Anything peculiar or innovative in your thing that you...
I have done a lot of upgradations and modules in my Tally software, which includes right from billing to discharge cards. There are 3 or 4 modules which are generally not available in Tally. I have customized them over a period of 20 years. And there are 3 added modules in my software over here, which gives me all the data on the tip of my button whenever I want. So it becomes, my life becomes very easy, where for that patient, I want his discharge card, I want his bill, which are the 2 most important things that, you need to look into it. If there is any complaint about the bills or, the discharge summary is not correct, then it makes my life very, very easy. And those typings are done by my secretarial staff. I only autocorrect them as and when required. So before the discharge is printed, I scrutinize it. But I don't do those medical typings. I've trained my secretarial staff to, whatever is handwritten by the sister or the RMO as a discharge card, just feed it. And if there's any correction required, I will, before printout, I will correct and you give the printout. So that has made my life pretty easy for 20 years.
That's your secret of a single man unit. Can I put this to you, Dr. Sushil? Anything specifically innovative that has happened in your nursing home, different from the others? Basic technology.
I just said in my talk previously, like I try to keep my environment around very friendly, very family type. I know mistakes are done by people and even the staff does mistake, but I see to it that I don't shout it in front of patients or do anything. I just call them in my consulting room and then tell them where you have done the mistakes and try to improve. I tell them to improvise there.
So back to basics. You listen to what your grandparents probably told you.
Yeah, same thing. I'm an old-time doctor, so
Doesn't look like it, but I'm gonna again set up another pointed question over here. This is again, so Rajiv, let me put it across to you. Very clearly, we are seeing Manoj is running a relatively super specialty, multi-specialty setup. Dr. Sushil probably also has a multi-specialty setup, and even Dr. Vidya has a multi-specialty setup. You are working on basically a non-single specialty gynac obs vertical pillar. So how do you see yourself as an advantage or a disadvantage being a single specialty unit? And secondly, do you see a role in collaborating with a nursing home and a physician nursing home and a gynac nursing home to deliver better in those terms? And just give me your views on that.
So when we took it over and when we started off, it was purely OBGYN. And I've toyed with the idea of introducing other faculties many times because obviously we didn't have the occupancy and we are only 15 beds. But what happened over the years is the challenges of staff have been the biggest. And for me to be able to cater to other faculties, I would obviously need that kind of staff because untrained staff who've done only obstetrics for 20 years and gynecology, if I bring in male patients into the nursing home, or if I bring in physicians or even medical oncology, to give chemo and all, then my staff is not going to be capable of handling those situations. So that was a big challenge. We did toy with the idea. We have done surgical work. You know that you've operated a lot at my place. But of course, like we've always tried to keep it female only. I think we would have operated general surgery on male patients once in 2-3 years. So again, that itself has an advantage because we are known to be a women's healthcare center. So we do get a lot of general surgical work or medical work sometimes, which is but only women specific. So we don't admit male patients. Now that has a certain niche. It has a certain advantage. Well, we are not catering to 50% or 60% of the population because we don't cater to men and children. But I think it's a tough balance. If we were going multi-speciality with male and female, then there are a lot of our obstetric patients who would not find the nursing home to be really that personalized or secure anymore. So it's a juggle. You got to consider the financial numbers. You got to consider the staff availability. And you also got to consider your personal growth. Now, it is so happened that personal growth has come from being attached to other hospitals as well. And like I said, in our area, peculiarly, we don't see 10-15 bed places surviving for very long financially. So though we had toyed with the idea of going multi-speciality, I think at the end of the day, as you grow a little older, your personal choices will matter. If you want to jump in, put in money, get a funding partner or get a VC and expand and take more space and get a larger property, then I would definitely recommend multi-speciality also. But I think Dr. Ganchamrani mentioned on the chat, and I think it's a fantastic idea, that we need more 50-60 bed single specialty or dedicated boutique hospital type of places. So I, like a women and child center or like a only women healthcare center where you can do all faculties catering to only women. These kind of specialty hospitals exist all over the world. I think we have a dearth of them. So probably for the next generation, if they want to do something different, I would, instead of choosing a multi-speciality, everything khichdi in one, sorry to use that word, I would rather go with, something like that. Something like, let's say, we do a women's healthcare for all branches of women's health, or we do a women and child only, or we do a surgical specialty where we concentrate entirely on minimally invasive surgery for everybody, for everything. So daycare centers. So some sort of specialization in the 30 to 50 bed space, according to me, will work very well. The moment you go into the 80-90 bed space, then you have to go general all specialty because you got to fill your beds. The financial implications are different, and you have the infrastructure to cater to more faculties. So you got to consider what type of project you're looking at if you're starting new.
So Dr. Sushil, I'm going to ask you the question that Rajiv probably skipped there. What do you see the role of collaboration of different specialty nursing homes with each other? Do you see that as a role, or does the tertiary hospital take that over?
In fact, it is the need of the hour now. It's difficult for one doctor to run a hospital. And previously, okay, people used to do, because that time the cost of your land, hospital, even putting up a hospital interior and getting the instruments are not so cheap nowadays. In fact, to start a small hospital, you have to spend not less than 5 to 10 crores, and which is not a small amount, you know. So if you got a team of doctors, like very rightly Dr. Rajiv said, you have one faculty hospital, which is very good and innovative idea. In fact, it's an idea which people should take a jump into it. But I know people, doctors are very insecure about that part. Will it run or will it not run? But it can be done with a proper way of digital marketing, people knowing what exactly we are going to serve to the people in that one faculty. It will be done. And I think now the team of doctors, like let it be physicians together, 3, 4 physicians coming together, or maybe a pediatrician coming together, or gynecologist coming together and starting a hospital. It really shares your work also. Because see, working 24 hours round the clock, 365 days for a doctor becomes very taxing. Somewhere you have to burn, then you start burning out. And it's over the last 10 to 15 years, because of the Google, WhatsApp coming up, your time in consultation is more nowadays. It's not like previously you can do consulting 5 to 10 minutes and people used to go out. They have a lot of questions. They come up prepared with the questions. And out of all those health packages coming up, they come up with the reports of 30, 40 pages and small, even elevation of any small enzymes, and they will ask you 10 questions on that. What is going to happen? Is it going to be risky or not? What should I do for it? Even we know that 41 SGPT is not going to cause a problem, but they will ask, my liver is damaged now, I'm going to die. So all those questions are there, we have to really answer them. Previously, we should never do all those things like this. Our questions used to be not come directly, it used to be only a disease part and just explain them whatever the problems they are going to crop up. So I think once you come as a team, naturally your work divides. You have to think somewhere the doctor has to come at satisfaction level, and they have to think, okay, as a team we can work. Maybe you can have 1 day of emergency, another 5 days you can just relax. That is what normally in other outside India people do that way, and they do enjoy working also, and they do enjoy relaxing also. So off-duty relaxation is also much need of the hour when we come together as a consultant.
Yeah, Rajiv has actually been that. He started his practice along with a partner gynecologist. And I can see him regularly taking holidays, and I envy him so often on that. Okay, now I'm going to try and end this session here by very pointed questions to all of you once again. Like, as you're looking ahead, right, what do you, Dr. Sushil, I'll take it with you first. What do you envision are the key threats, the key opportunities, and your base for small hospitals in India, and your recommendation to aspiring doctors who want to open a small hospital? Just keep it in minimum words, and the key threat, the key opportunities for small hospitals, and your recommendation for the new ones.
The one thing is that small hospitals are going to be there because we are catering to lower middle class people. So lower middle class people cannot go there. Those who don't have cashless facilities, they are going to come to small hospitals. So small hospitals are going to be there. Now the threats are only cashless problems. As Dr. Manoj very rightly said, the packages which we get, they are very small and they try to create a lot of pressure on small hospitals to accept those packages. I think once we all doctors get united, we can surely talk to all the GIPSA people and the insurance people to hike the rates. But we have to be united for that. Because most of the time doctors get that insecure feeling and they go alone and then they pay those whatever 4-5 lakhs to the insurance company and get the packages, whatever they give to us. So actually that should be avoided. We can be together. And regarding the aspiring doctors, as we have said, they have to come as a team now. You just can't go alone and open a hospital. They have to come up with a team and start a setup. And see, as a population of 138 crore, the disease is going to be there. The people are going to be there. They are going to get ill, and we doctors has to be there. Nobody can just detach us. Thank you.
Perfect. Thanks so much, Rajiv. Can I point these same questions to you? What do you see?
So very briefly, the threat I feel for starting a new place or for existing places is going to be managing the financial implications along with the issues of staffing. Staffing is really becoming a very, very big issue, especially in urban areas. The opportunity I see is tremendous if you are a little careful about where you want to set up your practice. Like I said, there are certain parts of our urban cities where you have just too many middle level and tertiary hospitals. Going into one of those areas and opening a smaller place, I don't think makes financial sense. I'm very ruthless about it. But like Sushil said, this is 1.4 crore people. We are always going to need more healthcare institutes, and there's ample opportunity. So I am a big optimist on opportunity. The last point about what advice for them: hardcore group practice. Whether it is coming together financially to open a setup together, or even if you are individually attached and working out of 5 places, group practice. You got to keep the rapport with every faculty in your area, even in your own faculty. I practice in a 6 kilometer radius. We must be 30, 40 gynacs, but 10 of us are so close that we are one phone call away. And forget emergencies, even in routine cases, none of us works alone now. None of us works alone, because work-life balance will come only if you do group practice, if you keep a good rapport with people in your area from all faculties. Like Manoj said, you should have 15 anesthetists who should be willing to come to you when you need one, because the day you're in dire straits, 14 will be busy. And it so happens with all of us, not just your own faculty. If I need a general surgeon to come when I'm having a complication at a gynecological surgery, I need to be able to reach out to 7 people. Not one should say no to me unless they are genuinely busy somewhere or they are traveling out. So group practice, group practice, group practice. That's my biggest advice. We cannot compete with each other. Those days are gone.
Manoj, pointing the same questions to you.
As far as the threats are concerned for smaller hospitals for the younger generation, it is very difficult to get away from this license Raj. I've been trying a lot to make all these things easier for the newer generations, and a lot of young consultants do call me, or the nursing homes in trouble do call me, and I try to give them the solutions to make their life easy, with whatever knowledge I have. But this license Raj is still into existence, and it is difficult unless we have a one window approach unitedly from our fraternity to be asked to the authorities that there are 10 licenses required and we need it under one roof. So that's the biggest threat for any newer generation consultant to open up a smaller hospital. So that is as far as the threats are concerned, and again dictation by the insurance companies. The younger generation will be forced to accept the rates which they are currently accepting also, because you see in any corporate hospital also, a senior surgeon may not be ready to do a surgery at a lower rate, but the younger consultant or a full-time consultant is forced upon to do a surgery at a lower rate. So newer setups may be forced just to run the show of the smaller hospital, that will accept whatever rates are there. But if you accept the lower rates, you cannot give quality service. So these are the major threats for running a newer setups. The second question is about, how to survive for the small hospitals currently, is that you need to have a group and not a single person owned nursing home anymore. Whether it is your own family member who's a surgeon colleague, a gynec colleague, or a physician, or you have 3 or 4 fast friends who can open up a 15-25 bedded hospital, each gelling with each other, practicing in their own specialty, and be there for each other in the need of the hour. So unless you vouch upon a group practice, you cannot survive in today's age. Every surgery that you do, I personally feel gone are the days when you say I can operate everything from top to bottom. A simple gallbladder, if you're doing it laparoscopically, a simple hysterectomy if you're doing it laparoscopically, instead of having your nursing staff to assist you, or an untrained RMO to assist you, it's better to call a surgical colleague or a colleague who's trained in that specialty, pay him whatever as per your division is there, but have a comfort that your surgeon is assisting another surgeon to hold the camera, hold the instrument and assist you, or for open laparotomies also. They know what you are doing and your life becomes easy. So nowadays I always have a colleague who comes and assists me, or I go and assist that colleague, whether it is a minor surgery or whether it is a major surgery. And it's the question of being satisfied with what you're being paid. You cannot defeat the purpose. Everybody has to be happy. So you need to do a good group practice. which we are lacking currently. So if you want to survive, these are the important suggestions from my side.
Fantastic. Thanks so much. First, I'd like to thank all the panelists for having taken this time out. Before we end, I'm going to ask Dr. Vidya to please kind of, put the things together. I have a few points noted, with the panelists had come up with, which I'd also like to share later. And thanks, Raji, for answering a lot of questions which you put on the chat board. There is one question here, which very clearly seems to be a problem of somebody with a very abundant practice, is how do you manage OPD and OT time? So here's somebody who has this is not an urban problem at all. We are always struggling to generate that kind of OPD. Dr. Anjali Davle, she's a wonderful surgeon who has her own hospital set up, and I can understand why she has a problem handling her OPD and OT time. It's probably because of the kind of service she gives. And so time management is out of the purview today. And the other thing, Dr. Rakesh Bhade wanted us to address the elephant in the room in terms of referral commissions. I don't think this is going to be the right forum for that. But yes, just briefly, Dr. Vidya, if you can just put down the points that you've picked up from them, and I'll probably add the few other ones, and then we can have a last point, or one sentence from all the panelists before we close the session today.
Yeah, thank you, Gautam. So basically, to sum up, what I could recollect or what I could get is that yes, nursing homes and the smaller healthcare setups do form a majority of healthcare system, around 70 to 80%, and running them successfully is not a difficult task, which is message to a newer generation, provided you keep yourself updated technologically, digitally, and manpower wise. So you have a skilled technician, skilled staff basically. Apart from that, for new generation, a very good message is to start a group practice. Yes, it is an era of medical legal era, and obviously you're going to have more and more medical legal cases. So it's always easy to share the burden and share the medical legal responsibilities. Plus, have a work-life balance. So that's, if you want to add anything, Dr. Gautam, please.
I'm going to add exactly the points that everybody has put over here. I've been taking notes and I'm going to save this with me. So Manoj actually came up with where the basic problem lay was everybody's approach and outlook to nursing homes, whether it is patients, doctors, insurance companies, licensing authorities, they all have a different approach and outlook to that. We need to change that over time. And I think that can only happen by joining hands, getting into associations, speaking more in terms of what nursing home values and everything, so that it changes perception of people. Secondly, Manoj also talked about constant staff training and upgrading the services, which we definitely need to do. The devil in the box over here was the license Raj, and I'm thankful that Manoj is still working hard at it. And we wish you all the strength and energy and the power to get this thing done. And hopefully a lot of other nursing home owners will join you in that thing. Rajiv very clearly said, embrace technology. We are on an information highway. All right. We need to catch up to what our patients have already got over here. Google reviews, YouTube videos to educate them. Great ways to go ahead. Okay. And obviously group practice, which he's actually started way back in 2003. He decided to start it as a group practice, and that's how he's taken it forward. Dr. Sushil obviously came back with, some of the very basic stuff, which we tend to forget, is about empathy, creating a family with the staff that we work with, and not just create a boss and your other colleagues kind of relationship, make it a family affair. And also the fact that you're connecting with your local community for better outreach, whether it's a politician, policeman, or social workers in that area, it becomes extremely important. Everybody obviously said you need to upgrade. Rajiv verbalized it, that don't just upgrade your staff and people, upgrade yourself too. And everybody had another thing about coming up for the new people to come up with a group practice. Fantastic. I think this was so enlightening. All three of you have been amazing through this whole thing. Dr. Sushil, it was wonderful to get to know you on this platform. Dr. Vidya, you too. Manoj and Rajiv have been great friends, but the insight you all have shared has been wonderful. Thank you so very much.
Thank you, everyone. So
Thank
let's
you, everybody.
conclude.
Just a small note, we are having a Bombay Nursing Home Association annual general body meeting on the 27th of April at Sunville, Worli, followed by dinner, which is free. So all are welcome. Thank you.
Dr. Gautam, can I add? When a when a VIP patient like MLA of your town, he comes to you for a gallbladder stone, he comes to you for a CA breast, and we know he is affordable person. He can have an utmost best services in the best of the city like Mumbai or even overseas. So in that situation, your proper guidance that, sir, you are not the person made to get the services at my place, you can have a better services as at XYZ person, gives you a more number of patients than operating that patient and getting yourself into a lot of trouble. That is only one suggestion I would like for the additional point whichever panelists have discussed. And thank you very much for a wonderful discussion overall.
That was Anjali being extremely humble. I know they're in the best hands when they reach you, Anjali.
Thank you. Thank you.